Oh. And we're live. Welcome, everyone, to the Melanin Initiative. I'm Alicia Brown and one of your co-hosts for the Melanin Initiative podcast. To my right, you have Geraldine and Kimberly as well. In healthcare, there's often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking down things into language you can understand. We create a safe space to ask your questions and share our nursing perspective without taking up too much of your time. Today, we'll be talking about anticoagulants, also known as blood thinners. By the end of the episode, our goal is that you'll be able to discuss what blood thinners are, and what they do and why they're prescribed, lifestyle changes for those taking blood thinners, popular blood thinners and what to know about them, and some safety considerations such as dietary choices, herbal supplements, and falls risk. Kimberly, lead us in our usual disclaimer of the day.
As a friendly reminder, everyone, this show is for educational purposes only. The opinions expressed here are our opinions alone. They are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. And if you or someone you know is having a mental health emergency, you can call 988.
So let's just jump right in. So blood thinners, what are blood thinners and why are they prescribed? So blood thinners are medication that essentially, there's your blood, the name suggests, but it prevents blood clots from forming. And as we've mentioned in our previous episodes, blood clots can cause complications such as heart attacks and strokes. So we want to avoid those at all costs. And the reason that they're prescribed is to prevent the formation of blood clots. Whether you have had some of the patients that may be on blood thinners or those that may have had cardiac surgery and had stents placed, for example. Also, and usually they're on blood thinners long term. You can also be on blood thinners short term, depending on if you're having a specific condition, or if you're hospitalized temporarily, since you're not up and moving as much, which puts you at an increased risk for developing blood clots. For example, last year I was hospitalized after having neurosurgery, and I was on a blood thinner daily. They'd come in and inject a blood thinner, common blood thinner that's used in the hospital is Lovenox. Enoxaparin is the other name for it, but that's one of the reasons that they're prescribed.
And we talked about heart attack and stroke in season 2, but also if you've had a blood clot in your leg, also known as a DVT, you might be placed on a blood thinner or anticoagulant as well. And you mentioned neurosurgery. That's another name for
brain surgery.
Yeah. Okay.
So some lifestyle modifications that you may have to make if you're on a blood thinner. Well, as Geraldine mentioned, blood thinners thin the blood, which means you are at higher risk of bleeding, right?
Yeah.
So you are more than likely going to be being careful when you shave, because you're going to be nicking the skin, bleeding, and it's going to take longer for the bleeding to stop as well. We'll talk about it a little bit later, but falling is a really big issue. It could lead to bruising and pooling of blood. You also want to be mindful of what food you're eating, because it could affect the medication that you're taking. But we'll also get there in a second. What other lifestyle modifications should we be looking out for?
All the things that would increase your risk for a blood clot. So that's all the things we've talked about all season long, which, while it might sound repetitive, is also a really great way to learn. That's how we learn, and during our education and training, is seeing these things over and over. So by now you should be able to say these along with us, right? And so what increases your risk for blood clotting? Things like high cholesterol, high blood pressure, weight,
smoking.
Yeah. Also
we leave that one first. It's an easy one to change, although the habit itself is challenging. Yeah.
Also, being on certain hormone replacements, specifically women that are on birth control, are at an increased risk for blood clots.
And if you're pregnant.
Yep.
Mhm.
And then
anything
one-
that affects circulation.
Right. And along those lines, sedentary lifestyles, so
Mhm.
not moving. So, I mean, even a short time span, such as being on an airplane,
Yeah.
Yes,
long car ride,
especially this time of year because we're traveling to see
Traveling.
everyone.
Yeah.
So we're sitting in the car, we're sitting in traffic, we're sitting on the plane.
Yeah.
You know, and that's super common in January.
right?
Yeah.
People just came, they went and saw their family in California. They spent 5 days in the car and they have no other health problems.
Right.
Right. And now they're here with a huge swollen
So,
leg and it's painful and it's red.
And it doesn't only affect your leg. That's a very common one, having a DVT or deep vein thrombosis. But you can also have what's called a pulmonary embolism, which is a PE where the clot breaks off from your leg and travels to your lungs
or your arm
and causes symptoms such as shortness of breath, sometimes some pain in the chest, discomfort.
I think Serena Williams did a really good job highlighting this disorder. So yeah, it's short for PE. And if that, just remember when you go back and you see our congestive heart failure episode, where we put a picture up of the heart and how blood's supposed to flow, when it makes its way up to your heart and enters your lungs, those vessels aren't big enough for that blood clot.
Right.
And so blood can't go further. And so, that'll be treated. Typically, so she mentioned the blood thinner. It stops new blood clots from forming, but it also stops the ones that you already have, because we have blood clots all the time. But our body makes its own natural blood thinner, heparin, and so it prevents the blood clots we have from getting any bigger.
Right. So I'm going to take you through a real life scenario,
Yeah,
right?
let's do it.
So we come into the hospital, you're having pain and swelling in just that right leg, and it's warm to the touch. And you're like, something's not right. You just went on a family vacation. You did a cross-country trip from California to Virginia. And by the time you got to Virginia, just that leg does not feel right. So the wife says, let's go to the emergency department. You go in, they take a look at it. They're like, that right leg doesn't match the left leg. So let's get a scan and let's see if we see anything. They do a scan. They come to find there's a clot in that right leg. As expected, it's classic symptom of a clot. So the next point is, well, what do we do now? Now there's treatment. So I will let our providers on the call here today.
So that imaging is usually an ultrasound.
Right.
It's not painful.
No.
Your leg is painful and we will treat that. But the ultrasound itself is not painful.
Just a picture.
Yeah. And it's more common to have it in one leg, but you can have it in two extremities, whether it's the arm or the leg. And anytime you have a foreign object in your body, it increases your risk. So, and we've covered so many topics, ladies. Pacemakers,
cardiac stents,
catheter stents, all those foreign objects increase your risk for blood clots. So you might be, even though you've never technically had a blood clot, they might still put you on a blood thinner because of that.
Just to decrease that risk of developing one.
Yeah.
So what are some of the common treatments for a blood clot?
Oh, so do you go primary care first if that's your first stop? They might give you a referral to an imaging center, and they're going to do the same thing.
Right.
Yeah, and some of the medications, I'll just throw some out there that we commonly see: Xarelto, Lovenox, which is the injection, which you can also although I got that in the hospital, there are patients that after they've been diagnosed and they still have to, when they are discharged from the hospital, they may still need to be on that Lovenox, and at that point it's kind of is a little scary for some people, but
understandable.
Yeah, because they have to go home and actually continue that medication and continue injecting themselves, which I think that's the scary part. That's usually one of the issues sometimes with discharging patients. They may not feel comfortable with injecting themselves, and it's important that they feel comfortable prior to us letting them go, because we don't want them to go home and not take the medication, because then they're going to end up right back in the hospital.
Worse.
So exactly. So we definitely make sure that they are ready and able to inject themselves, or have someone there, like a family member, that can inject as well if the patient doesn't feel comfortable doing it.
So your bedside nurse will be the one coming to do the education. So you've seen them do it. They're going to come in and ask you to do it in front of them. You do have to demonstrate that for discharge. You can't just tell us you know what to do.
Yeah. Other medications includes another one, a common one is Coumadin. With that one though, it's it requires a little bit more monitoring, more frequent monitoring as far as blood levels. So if you can be on that medication at home, but you may have to go in a couple, maybe one, is it like usually 2 times a week, just depending on your dose, to have blood levels drawn. And we're looking at your INR levels to determine if you are what's called therapeutic, meaning that you're on the right dose of the medication. And if you're not, if the levels are off, we would either increase the dose or decrease the dose.
Product is another popular one.
Mm-hmm.
Yeah.
Mm-hmm.
There's a lot of them. There's a lot of them. Yeah.
So I think the message to drive home here is the treatment option is going to be specific to you and what you have going on. So it may be that you are taking the medication to prevent a blood clot, and that's going to be more of a preventive dose, and the duration of that is going to be different than someone who has an active clot, or if it's one clot, multiple clots, multiple locations,
Right.
And your kidney health, your liver health, all of those things are going to be taken into consideration when we give you a treatment option. And also, as Geraldine mentioned, sometimes maybe the best option for you is the injection. But if we know that you going home on an injection isn't going to work, the provider will send you home with an oral agent to still give you the treatment that you need. We're always going to send you home, and it puts you in the best scenario for success.
Right.
So
Because
that's
we don't
important
want you
to
back.
know.
We don't want you back in line.
Exactly.
We love you, but we don't want you back in line.
And that sentiment is usually shared. Duration is the length of treatment, like how long.
Yes.
How right? Because some people might be on it for short term, right? Post-op or after surgery, and then some people might need it lifelong.
And then something that is kind of unique to the inpatient setting is there are medications that you get sometimes in the hospital that are a little more, I'll call the word intense, but you don't feel any different. So that catheter or that catheter that we put in your arm, we may give you medication that's continuous to kind of, when we know that you have an active clot that's really causing some harm, and we need to get you really active current treatment, like right now, because sometimes these blood thinners take a little bit of time to work.
Yeah.
But we need to give you something right now because you're at such a high risk of having a blood clot, or the clot is really active. So we're going to put you on a drip, and we're going to give you some medication through that catheter, and it's going to be continuous. But one of the effects of this continuous medication is that we have to monitor it. So similar to what Geraldine was talking about in the outpatient setting, going in weekly or biweekly for lab draws, we have to do it pretty frequently on the inpatient side. As frequently, it could be every hour, depending on where we are in the treatment process, or maybe every 6 hours, or maybe once a day. It really all depends on how where we are. But the purpose of that is to make sure it's at the right level in the blood so that it's doing its job. And that's whether you're inpatient, doing an active treatment, or outpatient, we have to make sure that it's in the correct level of the blood to be doing its job.
And a drip is another word for that liquid and medication that's in a bag that connects to the catheter in your arm. So it drops. There's a little drop. Right. So we call it a drip.
The specific drip that you're referring to is the heparin drip. So just to throw another name, one of the medications that's commonly used.
And that's a synthetic form of the heparin that your body makes. So your body makes heparin already. And then we can use a small little needle, what we call sub-Q. It's really tiny and it's very thin. And we can inject that in an area where you have fat. The most common places are the belly and the arm. So I don't know if I've shared it. I think I shared it here. I was a travel nurse. So one of the facilities I was at, it might have been that cardiovascular surgical unit. They really emphasized doing it in the belly. And they were saying that, research shows that it's better absorption there. So that was kind of just like, we didn't even give patients options. But typically I'll say, do you have a preference? And I'll give them body options that are preferred. Some people even like the thigh, especially if they've been stuck a million times. And we squeeze your body parts so that we can separate the fat from the nerves, which are below there. And the more fat you have, the less you're likely to feel it. So I do feel really bad for my patients that are quite thin and frail, have very, very little body fat. It becomes a challenge to find an area. But if you have been blessed to be a little bit more on the fluffier side, then you're less likely to feel that. But everyone's so different.
Yeah.
Some people like do it in the belly, I never feel it. Some people say do it in the arm, it's better. We were talking earlier, I haven't figured out, maybe if you know, a surefire way, because everyone's experience is so different. And so Geraldine's going to share a little story with us, but before she does, so your body makes heparin, we give you that little injection, but then if, say, you're at home and you take a pill, and then we need you to go to surgery, well, we can't have you taking a pill we can't control.
Right.
So we might put you on that heparin drip until your surgery's over and you're in the clear. It doesn't look like you'll need to go back anymore. Or like they mentioned, bridging you. So you'll stay on that until you reach your pill kind of gets you therapeutic and you can go home.
Right.
But yeah, Geraldine, you had a personal experience with receiving them.
Yeah. So my personal experience, as I mentioned before, was last year when I had my surgery and I was in the hospital for a couple of days after surgery. And because I had neurosurgery, I wasn't up and walking like I normally would. So it was very important that I got that Lovenox injection, and not very pleasant experience. And it was just interesting to be on like the opposite end, because for years I working as a registered nurse, I was administering the heparin and the Lovenox, and I'm just like, okay, let's just do this. But being on the other end, I kind of got to like experience what the patients are feeling. Not very pleasant feeling. Same situation. They squeeze usually I get it in the abdomen. They squeeze the fat and then inject. And for me personally, it didn't hurt during the injection. It hurt after. Like it was like a burning. It's not like excruciating pain, but it isn't pleasant. Fortunately, I wasn't hospitalized for long, so I wasn't receiving it for that many days, but I was definitely, it made me more sympathetic to patients that are in the hospital for months getting, and they have to get this medication like daily or sometimes 3 times a day, depending on what it is. So it definitely kind of opened my eyes and made me more sympathetic to those patients and their experience with it.
Yeah, it's usually 8 hours, and that's because it's powerful, but it's short. It's short acting. Like it doesn't last as long, the effect, which is great in the hospital, because if we want to do surgery in the morning, we want something that's not going to work in the morning when it's time to go to surgery, because we're cutting you open. We don't want to lose more blood than is necessary. So it decreases your chance for clotting, but that means that you're going to bleed longer till that clot develops.
So from like our nursing perspective, and I'm sure I could speak for both these ladies here, what we found commonly was patients refusing their blood thinners and anticoagulants because of the reasons that Geraldine just spoke about on the receiving end. We know it's painful. They get annoyed. They don't. Why do we keep doing this every 8 hours? We're waking you up in the middle of the night to do this. It's not always a pleasant experience. But when I tell you, it's life changing. Having a blood clot will change your life. And the risk of it really truly is death. So it's so important to be on some type of blood thinning or anticoagulant medication. And even if you're not on medication, in the hospital, we may put on these special devices that we call, the technical term is a sequential compression device, but we call them SCDs. And what they really do is to help circulate that blood in the lower extremities, because remember that sedentariness, that pooling. That's
like Geraldine said, she wasn't walking.
She wasn't walking.
We forgot to mention that's the whole reason.
That's the whole. In addition to getting the Lovenox injection, I was also hooked up to those SCD machines, and that's another thing. Some patients also unfortunately refuse it because it's just annoying for them to have it, but it's so important because it's compressing the leg. It's in basically the device basically squeezes your leg, and then and then
some people describe it as a massage,
right?
And some people don't,
right?
But the unfortunate part about those machines are, in order for them to be effective, they have to be on for 18 hours a day out of the 24. So
normally that's how much you would be moving.
Right. So that's the other piece of it. And they have to be on pretty much almost all day in order for them to really be effective. So that's why treatment isn't the only offering that we're going to give you. We're going to say, we want you to put those on plus the medication. And those two in combination will really decrease that risk for you to develop a blood clot.
And there's the TED hose.
There are
compression socks. I told my mom, we did a lot of traveling. If you're going to do a lot of traveling, get you some compression socks. And you can do the TED hose, which are
comfortable.
It's hard to get on.
When I tell you, I used to break out to a brisk sweat trying to put some things on patients.
But I have to give credit. I can't remember if it was tech or physical therapy, but one of them told me what you do is you put you cut a plastic bag, put it over the foot, just enough over the foot, and then you can slide the back on and then pull the bag through the toes, because the toes have a hole.
Yeah.
Because we don't need your toes to be compressed. And then that makes it easy. Because in school, it's on a mannequin, which is slippery. But on human beings, different sizes and have pain and aches, and you pulling super tight and figuring out the right angle. And then it's like, and you have to look at their skin, so you have to do it. You're supposed to take them off and give them a break every day. It's a process.
Yeah.
But they work.
It's all about that circulation.
And they have to be placed properly, because they can cut off your circulation and leave marks too. So you can't just roll them down like regular socks either. If they really aren't comfortable and you can't tolerate it, let's talk and try something else.
And sometimes there's also different sizes. So if it's uncomfortable, you have to let your nurse know so that they can order you the right size.
Technically, you're supposed to measure the calf.
Oh, yeah, that too.
And there are instructions on like the proper millimeters of mercury, but
a lot of times it's just trial and error.
Especially in the hospital setting, you only have what they have available.
Small, medium, large.
Yeah.
So, you're kind of using your clinical judgment.
Right.
We do our best, folks.
All that stimulus. So every time you walk and your muscles contract, they pump blood back to the heart. And we talked about already how important that is. And so when you're laying flat, which is very common in the hospital, whether you just got admitted, you're about to have surgery and you can't walk yet. Maybe you're in pain, back pain. Maybe you just got out of surgery and we tell you can't walk. Maybe you're confused, so we don't let you get out of bed. Maybe you're on a new medication like that Lasix, that diuretic we talked about, and now your risk for falling has increased. We don't want you to walk. Maybe physical therapy hasn't been by yet, so we tell you can't. There's a lot of reasons people don't walk in the hospital. Maybe you're on isolation. Maybe you have COVID. We won't let you leave the room. So some of this is hospital induced,
right?
And that's why we have these other things. But it's a great point, right? Some people really refuse.
Yeah,
absolutely. And that's one of your patient rights, is to refuse. And so if you're willing to do these other things, maybe you don't want to take the medication, but you're free to walk. You have no fault. Your fall risk is super low, and you're willing to walk 3 times a day. Hey, just talk to your nursing staff about that, and they'll relay it to your provider, and they might say that's fine as long as you walk 3 times a day.
You don't have to take those.
They might not remove the medication off the chart because they are liable for that. There are certain things that the people who fund the hospital need to see documented to prevent what we know are complications. So they have to do that. So you might get frustrated if every new nurse that comes on offers you this medication, even though you've refused and told everyone you're not going to take it. That's because it's still there.
Yeah.
It's not going anywhere.
It's not perfect. It's not a perfect system, but it's what we have.
So medications, Geraldine brought up a medication called Coumadin, and that medication specifically has some dietary considerations with it. With that particular medication, you have to maintain the green leafy vegetables is the topic of conversation with Coumadin, and you have to you cannot intake more green leafy vegetables than what you were previously consuming, because it affects the absorption of that medication. So
and it can reverse the effects.
Of
the medication.
Exactly. So if you are taking that medication, your providers may have discussions with you about just some dietary modifications.
And the main concern there is vitamin K.
Vitamin K,
which is found in leafy green vegetables, and it makes the medication
not work.
So if you eat 1 green salad a day and now you're on this medication, don't go eat 3 green salads.
Right.
Yeah, just stick with the 1.
Also, there are some herbal supplements that can also interact with blood thinners, specific ones. I think
like garlic, ginger.
Yeah. The St. John's wort is a common one.
Yeah.
So you just want to be mindful. Like
all those herbals are not without risk, especially if you're taking your conventional prescription or over-the-counter medication. All we want, you don't have to stop, Just talk to us about it.
Yeah.
So we can make sure we're doing the right thing that's safe.
So it's oftentimes like people don't think of like herbal supplements when we're taking like your medication history. I always make a point to ask if people are taking supplements because you don't think of it as medication, but it can interact with a lot of different medications that you are taking or will be taking.
Even things over the counter. People say, I don't take anything, but yet they take sleeping pills, Benadryl, allergy medications. Also, what I change it to, you take any medications, anything prescription over the counter, lotions, potions.
Anything. Yeah.
Love the lotions.
I thought I would get more laughs when I added that one, but patients are so focused on the no that they don't even hear me say lotions and potions.
And then one other thing we really wanted to mention was just about falls. So, my goodness, how many, we could probably tell the stories about the patients who are on blood thinners and they fall. And now we have to worry about bleeding in the brain and bruising. And it just, the risk of falling and on blood thinners is just so high that we just really have to be careful if we are taking them ourselves, if we have loved ones that are taking blood thinners, and just really maintaining their fall safety at all times. So we're going to be extra vigilant, whether you're on blood thinners or not, in the hospital setting to ensure that you don't fall. And then it's also something to be mindful of when you have loved ones at home.
Yeah, because with our older adults, the brain gets smaller. So the space between your brain and your skull is bigger. So you can have a collection. You may have fallen, hit your head. You can have and have no symptoms, no problems. But then you have that collection of blood that's slowly building. And by the time you do have symptoms, we have a lot more blood in our hands.
Right. Yeah.
And I think we talked about bruising and all that.
Yeah.
And that's just because, especially as we get older, but no matter the age, that's just one of the side effects because you can bump something and that blood vessel is a little more fragile, and then they're so close to the surface of the skin, and then the skin is getting thinner that there's that black and blue, and nobody likes to see that. It can resolve, but it just puts you at a high risk for it just reoccurring. Same with the heparin and the Lovenox. Yeah. If you're with us for more than a week, that belly and that arm is going to be all maroon and purple, and we do apologize for that.
But once again, it's necessary.
All right. So today we talked about a lot, but we emphasized what blood thinners do and why they're prescribed, some lifestyle changes for those who are taking blood thinners, popular blood thinners and what to know about them. And then we also discussed some safety considerations to include dietary choices, herbal supplements, and how to prevent falls. So you can email us your questions or show ideas at tmi.melanin@gmail.com. Subscribe to our YouTube channel and follow us on Instagram, TikTok, and Facebook. Please share the show with your friends and rate the Apple Podcasts and Spotify and leave a comment. It really helps the show get more support and gets the message to those that need it. You can find our social media links and a list of resources related to our conversation today in the description box. We release a new show weekly on TMI Tuesdays at 10 on YouTube and all your favorite podcast apps. Follow, like, and share our content with all of your friends. Thank you for watching.
Bye.
Thank you, everyone.